I'm very, very pleased to have our speaker today. It is Dr. Robin Jump. She is an assistant professor in the Department of Medicine at Case Western Reserve University in Cleveland. And she has both a medical degree and a PhD, and is an expert in both infectious diseases and geriatric medicine. She has over 40 publications in scientific journals and won a Young Investigator Award from the Infectious Disease Society in 2011. She is truly one of the national leaders in improving care for long-term care residents, and I feel very lucky to have her agreement to speak to us today. So I am going to go ahead and turn it over to Dr. Jump. Everyone else is muted for now. So Dr. Jump, please take it away.
Okay, thank you so much. Thank you for a very kind introduction and also for this opportunity. I'm really delighted to have the chance to talk with everybody. And I also want to thank Rita Olands, who I think put us in touch, which was, she's a lovely lady, and I'm really glad to know her as well. So let's go ahead with the next slide. And that's my necessary evils, just going over disclosures. So there's nothing directly related to this presentation, but I have taken money from several drug companies, and I promise I use it to advance the common good. And these are my own opinions, not necessarily those of the U.S. Department of Veteran Affairs or the United States government. Okay, good. Let's go on. Now we can get to the good stuff. So 3 learning objectives. First, we'll review the Center for Medicare and Medicaid Conditions of Participation, or the MEGA rule, for antibiotic stewardship in long-term care. And then we'll talk about successful antibiotic stewardship interventions in long-term care. And then we'll finally conclude with strategies for implementing stewardship in long-term care. And at that point, I think you guys will have a lot of comments, and I look forward to hearing or reading what you have to say and then discussing it at the end of the talk. Let's go ahead with the next slide, please. So I thought we'd start off by actually just helping you figure out where to find the information, which I understand that most of the infection preventionists can find pretty readily, but some of the physicians that I've talked to struggle. So if you type in this specific Google search strategy, CMS Reform of Requirements for Long-Term Care Facilities, these 2 results pop up. And the first one is the actual legislation. So go ahead and advance the slide, please. So sorry, that's the first one in the red box. Let's go ahead. And this is what that link will take you to. So this is in the Federal Register. It's law, which means they won't back off on it the way that the Joint Commission has backed off on a couple of their requirements. You can look at this online. It's only 188 or so pages, or you can also download the PDF and look at it there. Either way is fine. I prefer the PDF because then I can go back to it. And obviously, I've not read the whole darn thing. What I do, though, is search using Command F or Control F and find the term or terms that I'm interested in, and that helps me focus my time with the document because it's really big. Next slide, please. And here's the entirety of the language in the legislation about antibiotic stewardship. It's on page 181. I'm sorry, it's only 185 pages. So on page 181, under infection control, the only statement is an antibiotic stewardship program that includes antibiotic use protocols and a system to monitor antibiotic use. It's not even, it's just one sentence. It's so small and it's causing so much consternation. So let's go on to the next slide. So here's where there's better information. And this link was also active on September 25th, so it's updated. And let's go ahead and click on that one, and we'll get to the next slide. So this gets us to the interpretive guidance. And go ahead and advance. And the one that you need to click on is the Advanced Appendix PP, the one that's in with the red box around it. That becomes effective, as everybody knows far better than me, in just over a month's time. And I think at that point, the link or the name of the link might change. It'll be phase 2 at that point, Appendix PP phase 2. This is where the interpretive guidance is, and this is what we had waited for, and I think finally came out sometime in July or August. Go ahead and advance, please. So here it is, the interpretive guidance or state operations manual. This one is 600 some odd pages, so quite a bit more content in there. And this also can be looked at online or as a download, and I also prefer the download for this one, again, because I can search for specific terms. Go ahead and advance, please. And this is the organization within the interpretive guidance document. So they have the F tag for specific sections. Then within that F tag, they have definitions, the intent of the regulation, guidance, procedures and probes, an investigative protocol, key elements of noncompliance, and deficiency categories. Not every F tag has all of these sections in there, but this is the general organization that seems to hold through. And the ones that people seem to pay the most attention to are the key elements of noncompliance and the deficiency categories. Next slide, please. So when I search for stewardship within the document, the main F tag that comes up is FA81, and it's on page 655, and it's for section 483.80A3. I am a government employee, but I don't know how to quote regulations, but you can see it on the screen. There's a couple other F tags that come up as being related to stewardship. One is F690, and that one's about urinary incontinence, and the other is F880, which is the one just before the one for stewardship, and that's about infection control. There's a few more that relate specifically to the role of pharmacists, and I defer to a pharmacist or a consultant pharmacist for having better expertise there. But they also have to kind of get involved in monthly medication reviews and appropriateness reviews, and that's where some of their F tags come into play. Next slide, please. So here's the intent that CMS writes about for the antibiotic stewardship F tag. They want facilities to develop and implement protocols to optimize the treatment of infections by ensuring that residents who require an antibiotic are prescribed the appropriate antibiotic. They want to reduce the risk of adverse events, including the development of antibiotic-resistant organisms from unnecessary and inappropriate use. And they also want to develop, promote, and implement a facility-wide system to monitor the use of antibiotics. So the two actionable items here are implementing protocols for antibiotic use and then monitoring antibiotic use. The middle one about reducing the risk of adverse events, I think is pretty tricky to demonstrate that you can or can't do it, because in long-term care, as you all know better than me, it's you're kind of subject to whatever else is happening outside of your facility, including the people that are being admitted and transferred from various institutions. And that influences what happens in terms of the rate of antibiotic-resistant pathogens and C. difficile in your facility. So I think those, kind of in a routine way, these things are already being measured. I do not anticipate that very many long-term care settings are going to be able to show a decrease in the rate of drug-resistant pathogens, but I hope they can show perhaps where the pathogens are coming from, as in present on admission versus detected after admission. Let's go on to the next slide, please. So the guidance. They want facilities to develop an antibiotic stewardship program that promotes appropriate use of antibiotics, these are the protocols, and a system of monitoring to improve resident outcomes and reduce resistance. And what they seem to want here for monitoring is not only monitoring antibiotic use, but also adherence to or conformance with the antibiotic use protocols that the facility has set out. So they also are very clear on this, and this becomes, I think, a low-hanging fruit. They want the antibiotic prescribed to have the correct indication, dose, and duration to treat the resident, while also to reduce the development of antibiotic-resistant organisms. And this is not that hard to do. So, if we're writing an antibiotic for someone because they think they've got cellulitis, then that's the indication. the dose and the duration should be spelled out. And for the most part, in long-term care facility residents that develop an infection in-house, it's usually 7 days or fewer is sufficient for a duration. And that's a relatively easy recommendation to get put in or measured to have within your facility. Let's go to the next page, please. So they also emphasize in the interpretive document or interpretive guidance the CDC core elements, which I imagine that most of us at this point know backwards and forwards. It's leadership commitment. Is there time and resources dedicated to someone who can do antibiotic stewardship in your facility? Accountability, who needs to report and understand and respond? Drug expertise, that's usually a pharmacist. Action, what are you actually doing? What are the protocols? Tracking, measuring antibiotic use, measuring adherence to antibiotic use protocols. Reporting, which is letting people in the facility know about what you're doing and how the facility as a whole is doing. And then also education, which we will also touch on more in detail later on in the talk. Next slide, please. So the protocols must monitor use. And the guidance specifically says they want to incorporate monitoring of antibiotic use, including the frequency of how often someone is monitored or how often antibiotics are monitored or reviewed. And they specify that they want antibiotics reviewed when the resident is new to the facility, when they return or transfer from a hospital or from another facility, and then during each monthly medication review. So there's no lack of opportunity for reviewing, or at least a call for reviewing antibiotic use. It's a lot. It's a lot of medication review. Next slide, please. And they also want protocols that assess residents for infection using standardized tools and criteria. We'll talk about those in a few more slides. They want to see a system of reports related to monitoring antibiotic use and resistance data. So resistance data is already being collected. So the new part of this is monitoring antibiotic use. We'll talk about that as well in a few slides. And then also education. And they want to see education to prescribing practitioners and to nursing staff on antibiotic use regarding what actually is antibiotic stewardship and also the facility's antibiotic use protocols. And then on top of that, in order to show that the education has occurred, it needs to be recorded as to how it was done. Was it verbal? Was it online? Was it in stand-up? And then how often? Is it only on hire? Is it it should be at least annually, so on hire and annually. Or is it being done, quarterly or through regular stand-up meetings or huddles or something of that nature? And I can't tell you what CMS will think antibiotic stewardship is, but I think if you're talking about anything related to the treatment or the prevention of infections, that kind of falls under this category as things that you're doing to inform about antibiotic stewardship and to inform about antibiotic-resistant organisms, which is the whole point of this. It seems like that should count for part of the education. Next slide, please. And the protocols must give feedback to the providers about what they're doing. So they need to get feedback about antibiotic resistance data. That can't be done to individuals. It has to be done as a whole for the facility. The providers need to know about their own antibiotic use or prescribing and their compliance with facility antibiotic use protocols. And again, the stewardship policy needs to, or the people enacting the stewardship policy need to record how and when the feedback is given. Next slide, please. The investigative summary that CMS describes is also not all that long, but is tricky. So do the protocols address antibiotic prescribing practices? They want to see documentation of indication, dose, and duration of antibiotics. They want to see a review of laboratory reports to determine if the antibiotic is indicated at all or if it needs to be adjusted. And they also want to see an infection assessment tool or management algorithm. That's your antibiotic use protocols when people are actually prescribing the antibiotics. And then the other part of the investigative summary is asking, is there a system to monitor antibiotic use? And they're fairly non-specific about that. They want antibiotic use reports or antibiotic resistance reports, which I think are different things. Next slide, please. So the key elements of noncompliance. Is there one example of this is a failure to develop or implement antibiotic use protocols that help ensure that residents who need antibiotics get them and get the appropriate therapy, and protocols that address unnecessary and inappropriate use. And they also want to know, did the facility develop and promote, or sorry, an element of noncompliance would be a facility that does not develop, promote, or implement a facility-wide system to monitor use of antibiotics. There's a lot of emphasis here on measuring antibiotic use with the idea, I think, that if you're measuring, then you know what needs to be changed. Unfortunately, the CMS, or maybe fortunately, the CMS can't say what to change, but they can ask for measurement, and that's what they're doing. Next slide, please. So they offer some examples of deficiency. So immediate jeopardy. The example that's given is that the result of a microbiological culture that indicated resistant bacteria that weren't communicated to the practitioner. The antibiotic wasn't changed, and the resident was hospitalized for complications. And an example of this could be someone that had a true urinary tract infection with dysuria and fever and full-on symptoms, and was prescribed something empirically and turned out to have a resistant organism, went on to develop an ascending urinary infection. The actual harm, so that's the next more mild category, is that there are no protocols or monitoring system. And the example they give there is 2 residents who are on antibiotics without an appropriate indication, and both of them went on to develop a C. difficile infection. I think most of us are aware of that happening on a fairly regular basis in acute and in long-term care. Let's go on to the next slide, please. I didn't put in the lesser examples here, but some additional F tags for investigation. F756 looks at the failure of the pharmacist to review and report unnecessary antibiotic irregularity, and also for concerns of unnecessary antibiotic use. And they also talk about FTAG 552, which is the right for the resident to be fully informed in advance about care and treatment, which I think can be hard to do in an emergency situation. But I think there's an opportunity here in the antibiotic stewardship setting in long-term care to say, look, I know that you really want me to prescribe an antibiotic for your mom because you think she's got a UTI, because the last 10 times she had a bad day, we checked her urine and we prescribed an antibiotic for that and she got better. Now there's new information, and so I need to make sure that you understand that there's some risks of prescribing an antibiotic here. Why don't we try something different? Let's try some hydration and time and see if that helps. If not, we can always do the antibiotic. That becomes, to my mind at least, a discussion that would meet this requirement of fully informed about risks and benefits of antibiotic treatment and offering alternatives. Let's go on to the next slide, please. All right, so let's talk about some successful antibiotic stewardship interventions in long-term care. Next slide, please. So working together with a colleague, Morgan Katz, we reviewed papers that described antimicrobial stewardship interventions in long-term care. There were 20 studies with quantitative outcomes. 5 of them were randomized control trials, and 15 were quasi-experimental analyses. In terms of their quality, 11 were good, 7 were fair, and 2 were poor. 14 of them had measurable changes, and those changes were reduced antibiotic starts, reduced total antibiotic use, increased adherence to guidelines, and reducing the incidence of C. difficile infection or rates of drug-resistant bacteria. Next slide, please. So the framework in which we used to analyze the studies that we looked at is a human factors approach, and this is the SEEPS model. And I'm sorry, I've forgotten what SEEPS stands for. It doesn't quite roll off my tongue, but it's a human factors engineering approach. And this is the part of the SEEPS model. It looks at the work system, and there's 5 components: tools and technologies, organization, persons, tasks, and environment. And the idea here, with all those arrows going all the way across your screen, is that if you nudge or move or change any one of these things, everything else is affected in some way or another, that everything is connected. So if there is, for example, under persons, if someone who is an infection control and preventionist leaves the facility, those tasks then fall into somebody else. The organization has to get someone else to come in. They may have to bring in new tools and technologies to make it easier to do the job so that the person is retained, or the new hire is retained. I'm not sure about environment. That's the one I had the least good handle on. Let's go on to the next slides, please. So these are some examples of the individual components, kind of appropriate for the long-term care setting. So tools and technologies are the objects that we use to carry out our work. An example of this would be an alert on an electronic health record or a pocket card with antibiotic prescribing guidelines. For tasks, these are specific actions within a larger work process. And so one task might be the act of administering a medication. That is one of the final tasks in the whole cascade that starts with a change in clinical status and then a decision to write for medication and so on and so forth. Another task would be a daily checklist of antibiotic monitoring criteria. Does this person still have symptoms? Do they still need the antibiotic? Do we have a microbiological result back that says we might want to change the therapy? Organization, this is culture and communication between individuals. So is there an incentive for following antibiotic prescribing guidelines? Or is there support from stakeholders for the promotion of stewardship? And this might be an example of getting like a resident family council to really get on board with and support the idea of stewardship and become engaged with that. Persons, these are the characteristics of the people within the work system, and this is really, sometimes it can be about individual personalities, but more than that, it's about people in their individual roles, and also kind of the experience of the facility as well as their knowledge and expertise. And sometimes this means bringing in outside consultants. And then environment. This is the physical, internal, and external environment. One example that we saw when we looked at these stewardship papers was placing a commitment poster in a high-traffic work area. Another example I can think of where the environment influences how antibiotics are used is another VA that I'm familiar with. They have one main tower, and they have a long-term care unit in that tower, and the ID practitioners also work in that tower. They have a different long-term care unit in a building that's about a quarter mile away, which is a long walk, and the ID practitioners don't go there, and the antibiotic use is higher in that other facility, even though the acuity of the residents is somewhat less. Let's go to the next slide, please. So as we analyzed all these papers, we found the numbers in green on the left-hand part of the slide show what the different interventions we're using. And it was heavy on tools and technology, as well as changing or trying to influence tasks. Next slide, please. So we also looked at these in terms of 2 additional components. One was their involvement of nurses. And remarkably, only 14 of the studies actually specifically involved nurses, which is surprising because how can you do changes in nursing homes without involving nurses? And the other part of this was their structured education, and that was actually the primary intervention for 7 of the 20 studies. So the things that led to sustained changes for the interventions, one was to compare local policy to published guidelines. Another was individualized feedback to providers. And the third was focusing on UTIs, or asymptomatic bacteria, so focusing on a specific syndrome. seem to invoke sustained changes. Next slide, please. So I wanted to go over kind of what works, and then we'll go to a couple of specific examples. What seemed to work overall to improve antibiotic use was going in the domain of organization. And the idea was that the change had to be integrated into the workflow. For nurses, it needs to be pre-prescription, upstream, before there's, when there's a change noted, appropriate assessment and evaluation of that change, and appropriate communication about that change to the prescriber. And that's maybe where an SBAR comes into play. So a nurse is able to communicate, the daughter thinks the mom has a UTI because there's a, quote, change in mental status. We've checked her urine as positive by a dipstick just like it was previously. We're not seeing any difference, but I still have to call you with the results. What we'll do is offer the resident some hydration, and we'll get back to you if there's a problem. That's an upstream intervention in a nurse's workflow to get them to work on those SBAR tasks, and that can be done with a checklist or a printed scripted sheet. For prescribers, it's a post-prescriptive intervention, and it seems like the best way to communicate with prescribers is via the EMR or some other electronic means that is accessible to them while they're thinking about the patient or the resident. So a fax that can go in the chart or that gets incorporated in the medical record somehow is easier to deal with than maybe a text or a phone call that kind of pops up out of nowhere and might disrupt the flow of some other process. And then finally, what also worked was getting people that have infectious disease expertise involved with what's happening in long-term care. I don't know that these need to be permanent changes. It might be someone that can be brought in, in the auspices of the papers that we reviewed. It was a permanent change that someone came in for a long time. But I wonder if in the current climate, in trying to be cost efficient, if having a consultant come in on a part-time basis or even a short-term basis to help set up antibiotic stewardship protocols and practices would be useful and lead to sustained changes. I don't know, but I think that's a reasonable choice to go in a resource-limited setting. Next slide, please. So some examples. This was work that was done by Barbara Trotner and Loda Modi. They did an intervention for catheter-associated asthmatic bacteria. And this was done in 5 acute and 5 CLC units at a VA medical center. They had a control VA site. On the CLC ward, and CLC stands for Community Living Center, and that's VA speak for long-term care. So they targeted nurses and prescribers on the long-term care wards. And they specifically did case-based audit and feedback and interactive slides. And the control sites were just given the slides and emailed some guidelines. Next slide, please. So this is the amazing part of what they are able to achieve. This is the monthly rate of urine cultures comparing the baseline period on the left, intervention in the middle, and maintenance on the right. And the y-axis is the number of urine cultures per 1,000 bed days of care, and then, as I said, time across the x-axis. And at the intervention site, the number of urine cultures went down dramatically, and it stayed down. So they were able to achieve some persistent change there, which is really impressive. Next slide, please. And here's the actual the outcomes for the long-term care residents. The proportion of asymptomatic bacteriuria cases really didn't change, but the absolute number went down a lot. It went down almost, or more than fivefold, from 135 down to 25 cases of asymptomatic bacteria. And again, the proportion of CAUTI cases didn't change, but the absolute numbers went down dramatically by about sixfold. The overtreatment of ASB went down by numbers and by proportion. And the undertreatment of CAUTI went from 9 cases to 2 cases, which is also a really good improvement. The percentage went up a little bit, but the absolute number of people that were undertreated did not. So this is by decreasing the number of cultures sent, and this is an example of an upstream nursing-centric intervention. It really improved what was happening for the residents in these long-term care wards. Next slide, please. So some other examples that worked to improve patient care were bringing in infectious disease expertise. So one of these was one that I did at RVA a number of years ago, and it's still going on, and it's weekly rounds by an infectious disease physician, and at that time that we had an NP working with us. And basically I went around once a week. We thought we were going to see people that were sent out from the hospital on long-term IV antibiotics and just follow up on those. That turned out to be only 25% of the consults that we saw. 75% of the consults were from the long-term care staff asking for help. And it turned out what they often wanted from us was someone with expertise to stand with them and say, it's okay not to treat. It's okay to not do antibiotics here. It's okay to stop at 3 days or 7 days. You've done enough. It's okay to go narrower. That was a large part of what we did. And so that communication took place face-to-face and also by formal recommendations and orders left in the electronic medical record. And we were able to decrease antibiotic use by 30%. Next slide, please. Another example of this was done by chart review, or two examples. One was Shira Dornan with Bolak being the first author, and they reviewed daily pharmacy reports for a long-term acute care facility. They assessed medical records and made recommendations to the providers via email, and that led to a decrease in both antibiotic use and T. difficile rates. And then Pate described doing physician and pharmacist review charts weekly. And they placed, I'm not sure how they did this, but they put non-binding recommendations in the chart that were not a permanent part of the record. This was a paper chart intervention. And they led to, their intervention led to a 21% reduction in antibiotic use. Next slide, please. And I think that there's also something to be said for culture as an important aspect of what's happening in the nursing home with regard to antibiotics, among many other things, I'm sure. So this is an example of, or this is a study that I did with a student. We looked at antibiotic use across 6 nursing homes. They were all of a similar size, and they were all a mixture of skilled and residential, so these were not LTACs. And the graph that I'm showing you here shows the number of antibiotic prescriptions stratified by the length of therapy. So the bright green being short course, the yellow being longer than 7 days, and that dark red being more than 30 days. So there's a wide array of antibiotic prescriptions that we're noticing across these nursing homes. So we couldn't look at appropriateness, we couldn't look at indications or anything along those lines, but we took this graph, or actually a similar graph, and shared it with the nursing homes and asked them, what do you think? So next slide, please. So nursing home A shared their data with us, but they would not get back to us and let us do interviews ever, which was really sad and might be a commentary on nursing home A. And nursing home E and F, when we asked to talk to them, their medical director, director of nursing, and the infection control nurse all sat down in the same room and talked with us together at the same time. It was amazing. One of these was in person, one was over the phone, and there was a clear interaction and there was a resonance among the individuals that were present. Next slide, please. When we talked to nursing home B, and we could only talk to the infection control nurse here, she said, I think the providers always listen when we talk to them about antibiotic use, but do they respond in the way that maybe we were hoping for? And the translation for that is, we can ask them to stop or narrow or change therapy, but they don't listen to us. Next slide, please. And then nursing home D, where they had been making improvements, the infection control practitioner said that, in the beginning it was kind of scary to step in and to question a doctor, but then I started giving them evidence, and I tell them the CDC's recommendation isn't that we treat for 14 days every time now. Can we cut it down a few? So the conclusions that we reach from looking at this, and this is just scratching the surface, is that the nursing homes like A and B, where there was a hierarchy or a lack of response or poor communication, had a lot more antibiotic use. The facilities in which there was less hierarchy and more egalitarianism and better communication had less antibiotic use overall. And so what this suggests is that the culture really influences the communication between the prescribers and the nurses, and perhaps the residents and families and the pharmacists as well. And that the better communication there is, it seems like the less antibiotic use there is. And I should point out, this graph shows the number of antibiotic prescriptions. We also looked at this in terms of days of therapy per 1,000 resident days of care, so that it was comparing apples to apples across the facilities and normalizing by their census. The graph showed up in the same order and in the same hierarchy, in the same drastic differences among them. Next slide, please. So let's move on now to talk about strategies for implementing stewardship in long-term care facilities. So this is, I hope, next slide, please. I hope we can help get this working in your facility or improving the great work you're already doing. So CMS is asking for antibiotic use protocols. And what I suggest is a focus on common infections, and this is pulling apart from the CMS language. They want to see diagnostic criteria, appropriate antibiotic choices, and they also focus on length of therapy. They very clearly want standardized assessment criteria. And the two best resources that I can think of that kind of list those out in a way that's been reviewed and looked over by experts are the Loeb minimum criteria, which are criteria that talk about when should you start antibiotics for someone who's in long-term care, and the revised McGeer criteria. And those are surveillance definitions for infections in long-term care. They don't always agree, the Loeb and the McGeer criteria, but either one would be a good starting point for what's the time to use antibiotics and for what criteria and what tests should be ordered and how should the evaluation occur. And there's actually already some antibiotic use protocols that are available for free at the AHRQ or AHRQ website, and that link is in the bottom of the slide there, as are the Loeb and the revised McGeer criteria. So you don't have to reinvent the wheel. There's antibiotic use protocols that are already out there that can be taken whole hog or adapted to your specific facility. Next slide, please. CMS also asks to measure antibiotic use, and they don't say how. So there's a few different measurements you can try here, or see how it works for you. This is the gold standard. That's days of therapy, usually normalized to 1,000 days of care or 100 days of care. And this is any dose of an antibiotic given on a single day. So if someone comes in at noon and they get a dose at 11 o'clock at night, that counts as 1 day of therapy. If the next day they get 4 doses of Keflex and 2 of Vanco, that still, even though it's 2 agents, counts as 1 day of antibiotic therapy for that individual. The pros here are that it does estimate the total burden of antibiotic use, and it tracks changes in overall use. And if you go by you can get a sense of what's happening with individual antibiotics as well. It does not measure length of therapy, and is also really labor intensive. Another common metric is defined daily doses. These are standardized doses of antibiotics that are defined by the World Health Organization, and they did this in part because you can, if the inventory from your facility is kind of by total grams or total amount of pip tazo ordered for a month, then you can apply the definitions. It does not account for dose adjustments made based on age of creatinine clearance, so it gets a little dicey when we start talking about Vanco dosing in older adults, for example, or people that are on dialysis. A way that might be more feasible in long-term care as antibiotic starts. This is the number of new prescriptions per month or per 100 residents or 1,000 resident days. And this measures the frequency of prescribing. It tracks changes in starts, It doesn't look at total antibiotic burden or length of treatment. And then another measure that I don't care for, but I'm throwing it out there, is the number of antibiotic prescriptions for duration of longer than 7 days per month. It tracks efforts to reduce excessive length of prescriptions, but it doesn't get to overall frequency of antibiotic prescriptions. I feel like antibiotic starts is the most practical to smaller facilities. To start using days of therapy, I think would be great for larger facilities or facilities that might be part of a network or a chain, because there should be IT support to help look at that across the system. All right, so we've done monitoring, we've done antibiotic use protocols and then measure antibiotic use. Next slide, please. And then the third kind of component of this is that CMS asks for is to monitor antibiotic use and resistance. So to monitor, that can mean a lot of things. One of them is, as we talked about earlier, they want prescriptions to be reviewed upon admission, upon return from a hospital or emergency room. Those that were started by a covering provider, just like there's the night hospital, I think there's also the night and the weekend long-term care facility, and then also reviewing antibiotics during monthly med reviews. They also want to see review surveillance of resistant antibiotic bacteria, and that's already happening. And CMS also asks for an antibiogram. This is hard to do, I think, sometimes in long-term care, and the utility of them also isn't really clear at this point in long-term care. To develop a good antibiogram requires 30 isolates of one species of bacteria over usually a year's time. And so this is hard to do for gram-positives in general in long-term care. It's hard to do for a lot of the gram-negatives, and so the antibiogram that comes from your facility may need to only include urine. One of the things that laboratories will do is sometimes they'll combine antibiograms, or they'll combine data from 3 or 4 nursing homes and then put that out as a single antibiogram. It's hard to know if that's appropriate or accurate or not. They do it so they can make the numbers meet the criteria for developing an antibiogram, but whether that means it works for your facility is hard to know. I think what's important here is to try to have something, and you may have to go back a year or 2 years or 18 months and only focus on urine. And I think also being clear in the antibiogram about the limitations of it, especially when that's shown to CMS, is also important to do. Next slide, please. So in terms of trying to meet what CMS is asking for, I feel like we can leverage all that data that's being collected and then share that as part of the feedback process and education process. So for example, there's antibiotic use protocols that you can adapt from AHRQ, and then find a way to measure compliance with those protocols. Maybe it's a once-a-month audit, maybe it's something more frequent than that, or maybe it's compliance with a specific protocol, like just for urine. And so you can give feedback to the individual prescribers there, which is part of what CMS asks for. And that also becomes opportunity for education. Dr. Smith, it looks like half the time when you're ordering when you think you're treating someone for a UTI, you're not actually getting a urine culture, and that's a problem. Our guidelines say, as do expert guidelines, that you need to have a urine culture when you do that. That's part of the education. Measuring antibiotic use. So we've talked about several measures that can be chosen, and that can be given as feedback to individuals. Dr. Smith, your rate of antibiotic use is 1/4 of what's going on in the facility, and we think that what you're doing is great. You're below the average in terms of antibiotic days of therapy. Keep up the good work. You can do feedback to the whole facility. Look, folks, over time, our rate of clindamycin use has gone down, and we're really proud of that. And part of what I want to have you guys hear from me also is that it's important to celebrate successes, and that gains momentum and enthusiasm for what you're doing. And then finally, this is also education for measuring antibiotic use. Explain why clindamycin is not such a great drug. It has a limited spectrum, and it predisposes people to getting C. difficile. And then finally, we talked about monitoring antibiotic use and resistance. So this is also an opportunity for feedback to the whole facility and for education. So you can look at antibiotic resistant patterns and say, look, our rates of methicillin-resistant Staph aureus have remained the same over the last year. Good job, because we're not spreading it around to our residents. Or you can, and this also becomes a place for education. What is methicillin-resistant Staph aureus? How can we improve upon this and try to make the rates go down if at all possible? So let's talk about some of that feedback. Next slide, please. So feedback can and should be done as written reports to all staff about overall antibiotic use, compliance with protocols, and surveillance data. And these are things that can be put out at the annual picnic or posted on common areas or some other way that it gets distributed, and then record how that's happened. And then also written reports to individual providers about their antibiotic use, compliance with protocols, and then written acknowledgement of that feedback from them, I think, is also important to get. And let me give you an example of what you can do here. Next slide, please. So this is an example of individualized feedback. Here's a metric, antibiotic prescription with dose, duration, and indication. The facility, about a little over half of people are remembering to do all three elements, but Dr. A, you are a star. You're 8 out of 8. That's 100%. Fantastic. Another metric here is urine culture ordered for residents with an indication of a UTI. The facility average is 80%. Most of the providers are doing this, but Dr. A, you missed it in 2 of the patients, so let's work on that, please. And that's education. Why is this important? And then there's length of therapy, comparing the length of therapy for the facility, length of therapy for Dr. A. It looks like Dr. A, sometimes when you're writing antibiotics a little bit longer than 7 days, that may not be necessary. Let's talk about those and see if there's a way to not do longer than 7 days, or let's see if those were appropriate, because maybe that patient that you received was someone who was shipped from another facility and is getting treated for osteomyelitis. And then it's as simple as reviewed and discussed antibiotic use protocols, the antibiotic stewardship policy, and antibiotic use. Initial those 3, Dr. A signs and date, the medical director or the antibiotic stewardship policy, or the committee director signs and dates, and then you're done. And the same report, taking away the stuff for Dr. A, can also be shared with the facility at large and say, this is the stuff that we're doing. We're doing great, and here's some places we can do better. Next slide, please. Education we've talked about a little bit. It needs to be to all staff at least annually, document the mode and frequency. It also should go to residents and their family members. This can be part of the admission packet. It can be part of information that goes to resident and family council. It can be posters or pamphlets, a lot of which are available at CDC or at ARC, that are put up in common areas. And antibiotic use protocols we talked about, the providers need to be made aware of them. And if you have them sign off, then they know that they can't deny that they weren't made aware of the protocols. They can't plead ignorance there. And then nursing staff should also be made aware of those. All right, last slide, please. I think we're close to the end. Yes, there is help. So, and I think, Dr. Angeli, you already had this to share with the folks on this call, together with some folks from AMDA, the Society for Post-Acute and Long-Term Care. We put together a template for an antibiotic stewardship policy in which you can take and adapt or ignore or do something with it that's useful for you in your facility. Within that, in the paper that, the PDF that should be available to you, there's a crosswalk between the policy and specific elements of the interpretive guidance document, so you can know why that particular line in the policy is there. And there's also a list of resources to help support your efforts. In the PDF, there should be live links. If they aren't, let me know, and I can send them tabled to Dr. D'Angeli, and she can send that out to everybody else. And these are all free resources, and there's one. They're all things that I've looked at and have been reviewed by my peers, and are trusted and reliable. And let's go to the next slide. And I think as we go to take questions, I will, there's a haiku, an antibiotic stewardship haiku to ponder. Oh, wait, it went away. Well, it'll come back to you. you want.
I clicked on something and I messed up, so sorry about that.
Okay, there it is. It's also the nice cherry tree blossoms. So here's my haiku. Do these bugs need drugs? Antibiotic stewardship, only when needed. All right. Thanks very much, everybody. And I'm happy to take questions.
Thank you, Dr. Jump. That was fantastic, and it prompted a lot of questions in my mind. And I particularly liked your use of the photographs. So I am going, oops, I just put the questions away. Let me open it back up. I am going to pull the questions over to the screen, so hopefully you can see these. So one person asked, I've been using the McGeer criteria for over 8 years. How can I be sure I'm using the revised criteria? I directed that person to the reference by Nimali Stone, 2012, and you had that at the bottom of one of your slides. So I will send those slides out. Do you have any other comments about that, Dr. Jump?
Nope, that's it. That's the revised McGeer criteria. There's some nice tables in there, so it makes it easy to take those tables directly out. One nursing home I've worked with just posted the tables as for the UTI criteria by nursing stations, and to help nurses understand kind of the upstream part of that workflow intervention about not getting urine cultures unless there was criteria that were met.
Another thing that I've shared with our small group collaborative is one of the homes sent in a tracking spreadsheet that they use, and one tab is just the tracking spreadsheet, and the next tab has the McGeer's criteria for UTI, skin and soft tissue infection, and I think respiratory infection. So anyway, that I can share that with this group as well. It's just kind of a handy way to have them right at your fingertips. Anyway, here's the next question. Can you speak more about the limitation of antibiograms? They seem to be necessary for facilities to develop a facility-specific treatment protocol as required in the phase 2 ROP. Also, the AHRQ protocols do not identify which antibiotic to use. Please comment. For instance, the Rochester Collaborative has antibiotic selections suggestions.
Right. So, and I think the AHRQ guidelines or the protocols didn't want to get into recommending specific antibiotics for lots of reasons, including that things change over time. In terms of the antibiogram, it's worth knowing in your region, is there a lot of resistance, say, to fluoroquinolones, for E. coli, for example, being one of the more common ones. If there's a 50% resistance to fluoroquinolones for E. coli in the region, like one of the main hospitals that's coming to you, then for folks at your nursing home that develop a UTI, you might as well, flip a coin as to whether or not the fluoroquinolone is going to be a good choice. I think it's worth knowing what the local resistance patterns are. Whether they can be developed specifically for your long-term care facility depends on the number of cultures that are being sent, how often they come back positive, and what the lab is willing to do. Some of the laboratories are not willing to provide an antibiogram, or they want you to pay for it, and that becomes problematic. So what do you do then? If you need to just have an antibiogram, I think that some of the local hospitals will be willing to share theirs. You can do that bit where they, the lab will combine several nursing homes worth of data, which we don't know if that's good or bad. I suspect it's not as helpful. You can make it just a urine-only antibiogram, which is also not ideal. Did I get all aspects of that question? I think there was something I'm leaving out.
Let's see. That was Jeff West. And Jeff, I'm going to see if I can unmute you. Oh, sorry. I'm a little bit slow with this thing. Jeff West, here you go. Jeff, you're unmuted. Are you muted on your end? Okay, I don't hear Jeff saying anything. Are you there, Jeff?
Or maybe
okay.
He can
yeah, he's unmuted, so he can go ahead and speak up if he wants to. I just wanted to ask a question about the antibiogram. So, yeah, there are some limitations in facilities of ability to obtain facility-specific antibiograms. And so, like, we have one lab in our, well, it's actually an out-of-state lab, but provides services to, I think, about 25% of the nursing homes in our state. And they provide a 6-month rolling antibiogram, but it's not, I don't think you can really call it an antibiogram, because they provide the last 6 months of isolates and their susceptibility patterns. So it could be only 3 isolates, you know, in that 6-month period of time. So it seems not quite right, but it's a little, it's timely, but it's not it's not adhering to the CLSI recommendations for antibiogram preparation. But that's one option that these facilities have. But what about a hospital that provides laboratory services, and it's like all comers? So the nursing home would get an antibiogram that includes inpatient hospital, long-term care, and outpatient isolates. How would that be? What's your opinion about that?
I think it's better than nothing. I mean, some of this is you have to be able to check the box and say, here, we've got our antibiogram. I think it would at least provide some data that, you know, fluoroquinolones aren't very useful for us, but look, Bactrim is a really good drug for most of the common urine pathogens that we see. So it's helpful, but I guess it's I hate saying this, but it has to, like, there's no easy answers here. It means that it has to be interpreted thoughtfully with some, you know, attention to it. It's not a one size fits all response, unfortunately.
Right. I did just want to mention, particularly for the people on the call, that we at the Department of Health are creating antibiograms for uncomplicated urinary tract infection and then for UTI in the nursing home population, based on national guidelines and also based on what we see in our state surveillance. This will be a starting point, not like it's the final solution, but it's something, it could be a starting point for a facility. I did just want to go back to Jeff West. He did a write-in. He doesn't have a phone, so he can't speak up, but what about the Rochester recommendations for antibiotics?
I like those a lot.
Great.
And Dr. Dunyadi and I are colleagues and friends, and we talk about this stuff quite a bit, and so she and I have gone back and forth and talked through a lot of these things. And you know, what she's done is based on evidence as much as she's able to, and experience when she can't find the evidence, because there are a lot of gaps in what we know. And she and I have talked about them together, and I think she's done some excellent work, and I like what she has to say. And you know, in terms of empiric therapy, I like Bactrim for UTIs, and I also like nitrofurantoin. There's, you know, people used to think you couldn't give that because of, unless there was a normal, it was on the Beers criteria for so long, and someone had to have a creatinine clearance above 60. That's now been looked at a little bit more clearly, and it's a creatinine clearance above 40. And I can't tell this for any of you to do this, but what I don't really get all that worried about it, even if the creatinine clearance is like 30, because I'm usually only giving this for 3 to 5 days. The fears about nitrofurantoin are based on when people were on this for, you know, weeks and months, and they developed pulmonary fibrosis. We're not doing that. We're talking about treatment of acute cystitis.
Great. That's a great comment on that. We are at the hour. There's a couple more questions if people are able to hang on, and if you are able to stay on just a minute or two longer, Dr. Jump, could you take a couple more questions?
Absolutely.
Thank you. So there's one here about delirium management without any signs. Wait for 48 hours before a UA is done. I guess that's
right. So that's, you know, so delirium has so many causes, and I think we've made this a self-fulfilling prophecy that if we look for problems in the urine, we'll find it, and then it becomes, that must be the reason for the delirium, and I think it's true and unrelated. I don't, with caution and with thought and with protocols, I don't think there's harm in getting a UA and urine cultured earlier than 48 hours, but I would caution people to not rush in with antibiotics based on the urine dipstick, because I feel like that when we do that, it kind of makes us dipsticks. Instead, I think there's other things to do, like hydration and checking medicines and treating pain and reorienting or giving somebody a stuffed animal or comfort or some visit time. I had a woman, this wasn't my patient, but the story of a patient from another provider, a resident from another provider. She stopped talking to her son, and he decided that she must have a UTI, and this went down as a change in mental status, and so she wound up getting Cipro over the weekend. The regular medical director came in on Monday and saw the patient and heard about the Cipro prescription, and she said, what's going on? And she talked to the patient, who was able to tell her it was Easter and he didn't bring me stuffed cabbage, and I was really mad at him, and so I wouldn't talk to him. So I would suggest that there's good reasons to wait that are about not giving people Cipro because they want stuffed cabbage instead.
That's a funny story. One more question. Dr. Dimyati's pocket card offers the option of waiting 48 hours before starting UTI treatment if the localized UTI symptoms are mild. And this is unique in that it might meet McGuire's criteria, but still treatment is withheld to wait for the urine culture results to come back. I actually asked Dr. Dimyati what proportion of her homes actually, did that, waited when they truly thought someone had a urinary tract infection. She was unaware. I'm just curious. We're curious about your thoughts on that.
So I feel like if you've been able to wait 48 hours and the person hasn't gotten worse, and if in fact they're feeling better, then there's no need to respond to that urine culture. If they're doing better and things have resolved, then just leave them alone and don't do antibiotics at all. If they're super sick, to start off with, if the symptoms aren't mild, then those people, of course, would get antibiotics right away because you don't want them to get worse and you're trying to get them better. And for those groups that are kind of in the middle, if this is the first time that we've gone on this path, or the first time in a while, I agree with the idea of waiting, and that gives an opportunity to try other things to see if it can be resolved. I can see the idea of waiting to start, and that way it avoids unnecessary or inappropriate antibiotics. But I think it's more of an opportunity for a careful observation period. And there's a great order set that was published in JAMDA in, I think, 2015 by Chris Cernich and David Nace. And I'd Googled Nace because that's easier to spell than Cernich.
N-A-T-H?
N-A-C-E.
Oh, Nace. Okay, thanks.
Yeah, I'll send you the reference if I can.
Okay.
And it's a careful observation order set. And so if somebody has a change in status or a suspected UTI, the idea here is to try hydration, to try to treat pain, to see what else can be done, with the idea that we keep an eye on them. We look at them more carefully for the next 2-3 days. And by that time, we'll know, is it real? Is it something really infectious making them sick? Or is there something else going on that we need to address?
Great, that would be helpful. Okay, so I just want to bring people's attention to the computer screen. This, I believe, is the template for an antibiotic stewardship policy that you shared with me.
Yes.
Is that correct? Great.
Yes.
So if it's okay, I will share this with our group.
Yes.
And we are about 5 minutes over. I really appreciate your willingness to stay on 5 minutes extra. We had a lot of great questions, including another one that actually didn't get answered, but I think we're going to have to sign off for now. Dr. Jump, thank you so much for a fantastic presentation. So I'm going to go ahead and end the webinar now. Thank you, everyone, for participating. Bye-bye.